Hi, everyone. This is Talkback. We've been having a lot of important conversations during what I call the age of Corona. We're concentrating on our health and, of course, the virus that is sweeping our country and the world. Today, I have a very special guest who I call a triple threat because he can talk about so many different things. He is a pediatrician who works with children with disabilities. He is at the NYU School of Medicine as a professor, works at Maimonides Hospital. He also is an expert in Jewish genetic diseases, which we'll talk about, and has been founder of JPatable, which is a screening service. I think I've mentioned everything. Dr. Ditchek, let me introduce you. There you are. Hi.
Hi,
Doctor.
How are you,
Good
Sheila?
to see you.
Thanks for.
Did I leave anything? I probably left a lot of letters and things out because you have so many credentials and so many things that you've done. But we're going to concentrate on those three areas, right?
Sounds like my mother got to you early. Yes.
Yes, a nice Jewish doctor, right? There you go. Let me talk about your background. First of all, tell us something about where you grew up. I know you're in New York City. I grew up there too. What it was like growing up and how you developed an interest in medicine, and particularly your field of medicine, which is pediatrics.
So thank you for having me. I actually grew up right here in Brooklyn, New York. I was born in Brooklyn, raised in Brooklyn, went to school in Brooklyn throughout much of my life, and ended up opening up a pediatric practice here in Brooklyn initially, as well as Manhattan. I was raised by first generation American born parents. They were born here in the United States. My grandparents were all from Europe. And I was raised in a very modest home in Borough Park in Brooklyn, New York, with parents who instilled a very good sense of responsibility to community. And I didn't have much interest in medicine until I was about 18, 19 years of age. And I think the critical point that turned me in the direction of helping those with special needs was when I was spending a year in Israel. I had volunteered at Al-Lin Orthopedic Children's Hospital, which specialized in children with spina bifida. And the first week there, I was ready to give it up because I felt that it was too stressful. And my father, who had very little formal education other than an associate's degree under the GI Bill of Rights, when he came back from serving in Korea, my father said to me, if you quit on those kids, you'll quit on kids the rest of your life. You can't give it up. So I stayed with it and volunteered the entire year there and ended up developing a career in medicine after that.
Isn't it so interesting how different experiences in our lives lead us to our calling, our interest, our passions, one way or another? And so that was how you got started. Very interesting. And so where did you go to medical school?
So I trained in my residency and clinical training was here in Brooklyn, New York at State University of New York Downstate, Kings County Medical Center. I spent 3 years there as a resident in general pediatrics. I spent an additional year training with Dr. Lawrence Finberg, who was one of the legendary pediatricians, academic pediatricians in the world. And I spent an additional year as his chief resident. And then I went on after that to my career at New York University, where I spent several years working and training together with Dr. Felicia Axelrod, who headed up the division of familial dysautonomia. That's the only purely Jewish genetic disease. I spent several years under Felicia's wing at NYU, learning about how to manage very high-risk individuals with genetic disorders, specifically familial dysautonomia, and developed a career with a very strong background in critical care and care for high-risk children and young adults.
Okay, so you started out with your interest in pediatrics. Did you ever think of veering toward another specialty in medicine, or was that it? Once you had that interest, you continued with it?
I think up until COVID, that was my only passion. It was pediatrics was where I landed, and pediatrics is what I loved. I felt that children were the greatest challenge to care for. Children at the youngest ages don't have the ability to tell you what's wrong with them. So pediatricians in general have very keen diagnostic skills that they develop over the years. I felt that being in the position to advocate for children was where I belonged. And that's where life led me. So I've never had any other passions other than pediatrics, but oddly enough, as I developed a practice and an interest in the care of children with high-risk conditions and genetic disorders, because many doctors don't want to care for those kids later in life. Many of my transitional patients are now young adults. And in fact, in the area of genetics, I have individuals who are well above the age of 40 already, who I've known for many, many years.
Oh, that's great. So we're going to get to a lot more about your work with kids, especially the project Kids of Courage. But before that, we want to turn to your work with Jewish genetic diseases. You're going to be giving a talk to our entire region of Connecticut on September 15th on the Jewish genetic diseases. And I want you to give us somewhat of an explanation now. Many of us are not scientists, so we want to be able to understand the basis of the science and then how you go forward from there to screening, understanding, and then treatment potentially, right? So talk to us about the Ashkenazi Jewish population, because I have been reading that over 80% of American Jews, for example, are Ashkenazis. What are the Ashkenazis? Where are they from?
So when talking about Jewish genetic disorders, we must include our Sephardic brethren as well, because quite frankly, there's a lot of mixed ancestry here in the United States, individuals who married into Ashkenaz and Sephardic families in both directions. But the majority of Jews who live in the United States are actually of Ashkenazic descent. That means that their families originated in, well, many of the families are obviously originated in what was previously known as Palestine back in the times of the Holy Temple. After the destruction of the Second Temple, Jews were forced to leave that area of the world. The Sephardic Jews left to the North African and Middle Eastern and Mediterranean countries, whereas the Ashkenaz Jews immigrated to the European countries, Northern European countries, what's today known as Germany, Russia, and those areas as well. So Ashkenazic Jews originated primarily, or for purpose of genetic issues, originated in those European countries. And because of the way the individuals' communities were either persecuted or fell victim to disease and other social issues within those societies, genetic disorders became much more prevalent, or genetic carrier states became much more prevalent because of what we believe to be the founder effect of genes. Now, these genes for Ashkenazic Jews and for Sephardic Jews, for that matter, while we view the Jewish genetic disease mutations as bad things, in reality, many of those genetic mutations were probably protective for things that were prevalent during those centuries. For instance, individuals who are carriers for Tay-Sachs disease have a much lesser chance of dying of tuberculosis and Black Plague. Those are two diseases that were very prevalent during the 15th century, 14th century European times. So clearly those mutations came about as a protective mechanism so people would not die of those diseases. So genes became much more prevalent during the 13th, 14th, 15th century. And as Jews immigrated together, as they moved together in large groups, they started marrying within their cohort groups, and those genes became much more common. Unfortunately, because before we had the ability to test, they did cause a lot of Jewish genetic diseases. Today, we have several screening programs throughout the world. The one that was started by me and several other people about 2 years ago is a program called JPatable, which we're now re-releasing August 21st of this year. The JPatable program not only screens for the full complement of Jewish genetic carrier states, but we also provide matching service for individuals who are getting married or engaged and are planning to have children. We inform them of what carrier states they might have in common, which would put them at risk for having a child, God forbid, with a genetic disorder.
Okay, let me go back and try to unpack some of that to make it more clear to people like me who don't have a scientific background but want to understand it better. So I always found it interesting that Jews as a people, probably one of the only people in history that survived without a country, because they remained isolated and stayed together. And is that one of the reasons why you can more easily do research on it and figure out what the are the genes that they are transmitting to their generations? Is that one of the reasons?
Yes, Jews typically, generationally, have married within their own communities, especially European Jews, obviously, and Middle Eastern Jews as well. And whenever you're marrying closely within your own religion, within your own faith, within your own cohort group, the genes that are present in that group will actually be propagated and will become more common as the years go on. So yes, the exact reason that the Jewish world or the Jews have survived thousands of years is that reason, that we've married each other, we've traveled with each other, we've immigrated with each other, and those genes have remained very true to our religion and to our people. So yes, that is the number one reason why Jews are at greater risk for genetic disorders, because we share common communities and common marriages, and often we immigrate together, and we often were persecuted together, which means that we moved together when it wasn't comfortable for us to live in those countries. So
okay,
yes,
now I want you, good, and I want you to also explain in more detail the founder effect, the idea that it was just a few Jews hundreds of years ago who have been transmitting to now millions of Ashkenazi Jews today. Explain exactly how that founder effect works, what it means.
So when a gene mutates, when a gene changes its DNA, for whatever reasons, whether it's pressure from environmental causes, whether it's pressure from disease causes that are surrounding that community, but when a gene changes, it develops what's called a mutation in its DNA. And when there's one individual who develops a mutation, let's say that there's effects on that individual's community, whether it's disease like the Black Plague or tuberculosis, or whether it's political persecution with pogroms. Jews are then reduced in their numbers geographically because they either died off or suffered from that persecution, and then they moved together. And when they moved together, those smaller cohorts of Jews now married each other and had children together. So that one mutation became much more common in families because they became more concentrated as they moved geographically together, and as the effects of that persecution or those disease states affected those communities. So one founder gene that occurred in region X after a period of years of either death, disease, or political persecution, as that community came together and married each other, those genes became much more common, and that's what we refer to as the founder effect of Jewish genetic disease mutations.
Okay. And explain the concept of mutated genes, because that is what carries the disease down through the generations. Explain that and how that works.
So a gene is comprised of many of those base pairs that everybody's familiar with, the DNA double helix, which is made up of billions of those base pairs that comprise a double helix of DNA. When the DNA changes for whatever reason, let's say there's an injury from a chemical that affects an individual's DNA, it can cause a mutation. That mutation is now what's identified as a genetic mutation. In the case of Jewish genetic diseases, most mutations require both members of the couple to carry the mutation in order to have a child at risk for having one of those diseases. Now, those mutations cause effects in how the gene works. Our genes tell our body to produce proteins. Those proteins are critical for functions in the human body. If there's a mutation in a particular gene, the protein is no longer produced in a proper or effective way, and it causes disease states very often. That is the definition of a genetic mutation. A mutation is a malfunction in the DNA structure of the gene. The gene can no longer put out the proper protein or the proper amount of protein instructions to the human body, and that results in disease, unfortunately.
Okay, so tell us now, let's take a couple, a Jewish couple of Ashkenazi descent. And by the way, how do people find out if they're Ashkenazi Jews? Do they have to go to Ancestry.com, or will they just know from their common living, from their experiences in life until they marry? I mean,
So It's a great question, Sheila. There really, other than some specific genetic mutations, there's really no true test of whether somebody is purely Ashkenazic or purely Sephardic. In my own family, when my children were tested for Jewish genetic carrier states, we actually found several of our children who had a very common Sephardic mutation. Now, I promise you, my family had absolutely zero influence of Sephardic ancestry that we are aware of, but we only went back to the early 1800s. We weren't able to go back genetically beyond that in my own family. So clearly there were Sephardic influences on our family's genetic outcome. But I'll give you the best example of why it sort of doesn't matter. The best example of shared Ashkenazic and Sephardic ancestry is the BRCA gene, the breast cancer gene, which we don't test for as part of our program. But the breast cancer gene, if you look at the genetic makeup of that gene, it is virtually identical. Not virtually, it is actually identical between Ashkenazic and Sephardic Jews. So we believe that the BRCA gene is one of the only genes that we've been able to trace back to the time of the Second Holy Temple, the Beit HaMikdash. And when the Jews separated, the Ashkenaz Jews went north and the Sephardic Jews went south geographically. Although their genetic makeup changed, it didn't change for the BRCA gene. So the BRCA gene, we believe, is very much evidence that Ashkenazic and Sephardic Jews originated in the same geographic area back at the time of the Beit HaMikdash. Going forward, there really is no pure test to tell you whether you're Ashkenaz or Sephardic. And quite frankly, with mixed ancestry these days, meaning Ashkenaz who've married Sephardic and Sephardic who've married Ashkenaz, vice versa, it really takes away the need to know. Because when we test in the Jewish Genetic Disease Screening Program for JPATable, we assume everybody is of mixed ancestry, and we test for the full complement of Ashkenaz genes. We check for the full complement of Sephardic genes and Mizrahi genes as well.
Okay, so a couple of questions are at the fore now. So you have testing facilities, you have JPATable, and you've done screenings. For the average Jewish couple that marry in America, how do they know and learn about the importance of getting tested? Where do they go? And why isn't it more of a protocol for couples that are having kids and that are Jewish?
So that's a very good point, Sheila, because unfortunately, many couples, if the couple is raised, let's break it down to communities. In the Orthodox community, it's standard fare for couples to get tested prior to marriage. And that's been going on for many years in the Orthodox communities throughout the world. Those communities have adopted early on the Tay-Sachs testing back in the 70s and continued on to today. For non-Orthodox couples, it's been a serious challenge to identify when they need to get tested. If we had our druthers, all individuals should be tested prior to family planning so they could know well before they get pregnant whether they're at risk of having a child with a genetic disorder. Unfortunately, what happens in most cases here in the United States is people show up at their obstetricians once they're pregnant, and the obstetrician, by standard of care, once they identify you as a Sephardic or Ashkenazic Jew, they will typically advise genetic screening at the time that you present to the obstetrician. That is not a good way to go forward because, unfortunately, once you're pregnant, you'll then have to make decisions about that particular pregnancy and that baby, whether the baby might be affected. So the education for Jewish genetic screening should start, in my view, in late high school and in the early college years for those who attend college. And we need to reach out to groups like yours to get the word out to communities all over the world that the standard of care has changed dramatically in the last 5 years. And quite frankly, we're doing a bad job because most people in communities where there's not tremendous influence from the Orthodox sectors, they do miss the opportunity to get screened before family planning. And I think that's a tragedy we can avoid in many cases.
Okay, that's a good answer, but it's a sad answer. I had 2 kids and I never even gave it any thought. And I read about it intellectually, but never did anything about it. But now the important question is also, So tell me, what are the chances, the proportionate chances that one has if you are an Ashkenazi Jewish couple having kids? And what are the various diseases that you are prone to have because of the founder effect and the genetic inheritance?
So the carrier rates vary dramatically. For Gaucher disease, which is the most common Jewish genetic carrier state, 1 in 12 to 15 Ashkenazic Jews carry that gene. So that's a very high carrier rate for any Jewish genetic disorder. In the case of more less common diseases, the carrier rates can be high as 1 in 300. What I always tell people is it doesn't matter if the disease you're a carrier for is 1 in 300 or 1 in 12. If you happen to have a common carrier state with your spouse, you run the same risk of having a child with a genetic disorder. If two individuals, if a couple is a carrier for the same Jewish genetic mutation, each pregnancy carries a 1 in 4 chance of, God forbid, having an affected baby. Each pregnancy carries a 50% chance of that child being a carrier for the genetic disorder. In almost all cases, being a carrier has no meaning and no risk other than the need for future screening when that child goes on to do family planning. But if you are both a carrier for the same gene, whether that gene is 1 in 12 in the case of Gaucher, or whether it's 1 in 130 in the case of a disease like mucopolysaccharidosis, one of those disorders. If you're common carriers for the same gene, you have a 1 in 4 chance of each pregnancy of having a baby with that disorder. And those are not good numbers.
Okay, so you said the most common is the Gaucher, and you say that both parents must carry the gene, right? Must carry it in order for there to have an issue with one of their children.
Correct.
Right? Okay. What is Gaucher? Why is it an important disease for us to worry about? What are its features, prognosis, and treatments? Help us understand that.
Gaucher disease is one of what we call recessive disorders. Recessive means you need a carrier gene contributed from each parent. It's a lysosomal storage disorder. It means that there's an enzyme that's missing in the affected child or the affected adult, and it fails to process certain metabolites within the cell, within the human cell. Those metabolites congest the cell and they get filtered out in organs of the body that can cause damage, like the liver, the spleen, the bones, and other organs of the body. So Gaucher disease is a disease that can have a wide variety of severity. You can have severe forms of Gaucher disease where you'll have bone destruction and involvement of your liver and spleen and other organs of the body by age 14, 15, 16 years of age. Or you can have mild forms where you'll go undiagnosed until the age of 40 or 50. The important thing to remember with Gaucher disease is, number one, it is preventable by screening. Number two, it's one of the few genetic disorders that when you go for screening, you will actually find affected individuals. And I actually, that's an area of my expertise. We call it naive Gaucher disease. It means that somebody is walking around with Gaucher disease and has no idea that they have the disease. This morning in my office, I saw a young father with his children who was a patient of mine. He was referred to me when he was about 14 years of age because he had some unusual findings. He had a low platelet count that his pediatrician was unsure of. It was referred to me after the hematologist couldn't make a full diagnosis. And that young man turned out to have Gaucher disease. Now, he looked perfectly healthy. When we did studies of his long bones, he had complete destruction of most of the bones in his body, the long bones in his body, without ever knowing about it. Once we found out he had Gaucher disease, we put him on, in those days, it was standard of care to use enzyme replacement therapy. We gave him infusions twice a month. Within 2 years, his bone disease reversed almost completely. And today he's a father of 2 who's an attorney as well. Today he takes an oral medicine called oral substrate therapy. So if you're above the age of 16, you can now be treated in most cases with a simple pill once or twice a day, and he will live a normal, full life. Had we not discovered his Gaucher disease, that young man very likely would have had severe bone destruction and bone disease by the age of 35. And if we didn't discover it by the age of 45 or 50, there would have been a strong likelihood of developing early Parkinson's or early multiple myeloma. So Gaucher disease left undiagnosed, even in those who appear to be mildly affected, can have severe effects later in life. And that's why it's the most important aspect of picking up actual disease states when we do Jewish genetic screening. In our program in JPATable, we find many Gaucher carriers, and about once a year, we do find an affected Gaucher individual who now identifies themselves as having Gaucher and can go on and get treatment and live a very healthy, normal life.
Well, I'm wondering do you have an estimate or a thought about what percentage of people out there have the naive Gaucher? I don't think there's enough, at least from my point of view, education about what the symptoms might be or how one might find out more about the potential of having that disease. It sounds like a group of eclectic type of symptoms, so it makes it hard to figure out that you might have it. What is your answer to that? How can we get more education on figuring out whether you might have it or not?
So for those who are symptomatic, it's pretty easy. They bruise easily because many of them have low platelet counts. Many do complain of abdominal pain chronically because their liver and spleen are enlarged. Many of them complain of bone pain because their bones are having these Gaucher infarcts, destroying bones silently over the period of their early life. And those are the primary clues to Gaucher disease when we're looking for symptoms or signs of Gaucher disease. Many of them have enlarged livers or spleens that their physicians will detect serendipitously. In terms of the incidence, we actually know the incidence because we know the carrier rate in Ashkenazic Jews is 1 in 12 to 15 Ashkenazim. The incidence is about 1 in 800 to 850 live births in the United States or in North America are babies that will be born with Gaucher disease. And there are actually, fortunately, states looking now at the newborn screening programs right after a child is born to include Gaucher disease in the screening programs after birth so we can identify affected babies early in life and make sure they get treated early in life. And by the way, the good news is if we can find children early in life and treat them about at the age of 5 or 6 or 7, they will never develop bone disease. They will lead healthy lives without the need for any further disease progression. But those are the basic symptoms that we're looking at: early bruising, abdominal pain, bone pain. Those are the very common findings that we hear about in Gaucher patients. So if you're an individual who bruises easily, who has a lot of abdominal bloating or discomfort and feels that you have frequent bouts of bone pain or unexplained extremity pain, you should be evaluated for Gaucher disease.
Okay, thanks. Thanks, doctor, for that. And now can you just give us some of the symptoms and the issues involved with a couple of the other diseases that are genetically inherited? For example, the Tay-Sachs, the one we familiarly hear about, but apparently it's not as common as the Gaucher. Talk about that one.
So Tay-Sachs is about a 1 in 25 to 32 carrier rate for Jews, depending regionally where they came from. That's about obviously half of the carrier rate of Gaucher disease. There was a time in this world up until the early 70s, the mid 70s, when we identified the missing enzyme in Tay-Sachs disease, that Tay-Sachs disease was quite common in Ashkenazic Jews. Most of us knew families, unfortunately, who lost children to Tay-Sachs disease. Tay-Sachs disease is a disease where the baby looks apparently normal for almost the first year of life, and then beyond the first year of life starts to lose their developmental milestones and eventually develops very severe seizures. And unfortunately, most of those babies succumb to the disease by the age of 2 to 3 or 4, and they pass away. Tay-Sachs disease is obviously universally deadly disease in children if they're born with it. Today, interestingly enough, Tay-Sachs disease is more commonly seen in certain non-Jewish populations because the non-Jewish populations haven't been as effectively screened for Tay-Sachs disease as the Jewish populations worldwide. So Tay-Sachs has reverted from a primarily Jewish disease to a primarily non-Jewish disease at this point. Other diseases with similar carrier rates are diseases like familial dysautonomia, a disease that I used to be the associate director for the division at NYU with Dr. Axelrod. That disease is also a very serious genetic disorder with about a 1 in 25 to 30 carrier rate. And that disease, unfortunately, causes terrible dysfunction of the autonomic nervous system. That's the nervous system responsible for everything you don't have to think about: your breathing, your sweating, your digestion, your salivation. Those children are born and unfortunately are generally very sick if they're born with that disease. Many of them go on throughout a very difficult life dealing with many medical issues. I've cared for a large number of them over the years. When I started working with individuals with dysautonomia back in the early 90s, the average life expectancy was about 6 years old. Today, the average life expectancy, thank God, with great medical care is about 19 to 20 years old. But unfortunately, it's not an easy life for those individuals.
Yeah. So those seem to be the major ones that we're discussing today, and there's a list of others. We've touched on the breast cancer, BRAC. I want to ask you about J-Patable and the idea of screening in advance, I guess, of getting married or even perhaps getting engaged. If you do get married and then have the test, what are the kinds of counseling that you get either from your religious people or from your medical staff about how to handle it if you might have a child with a genetic disease that could be disabling or life-threatening?
So J-Patable, we actually have primarily, we focused initially on individuals who are doing family planning, who are planning on getting engaged and then getting married and having children. About half of the people we test are actually married couples who've had incomplete testing to date. Unfortunately, the panels, or fortunately, the panels have expanded greatly in the last few years. So if somebody was tested in 2012 or 2016, they probably didn't have the number of tests that we're testing for right now. Currently, J-Patable, with our new program starting August 21st, we're testing for over 250 carrier states. The way the program works is it's a saliva-based program. They enroll online. The individual then gets a saliva kit in the mail. The kit is mailed back to our cooperating lab, and within 2 to 3 weeks, the results come back. We review those results with all enrollees. There's an option for every individual to go through genetic counseling if they choose. Some people choose extensive genetic counseling at the time of screening. Some people choose to delay that genetic counseling. What we do is we advise each individual not only in a written version of a report that they can pass on to their doctor, but we also do a verbal report where we review their results with them. If they're individuals who are engaged or planning on getting engaged, we will compare results of client A to client B without disclosing those results. We never disclose results of one participant to the other. The only thing we will say in that case is you do not have any common carrier genes that you need to worry about at this point. You're good to get married. You're good to do your family planning. We then give them a report, which they pass on to their obstetrician, so the obstetrician can have a level of comfort with what they were screened for to date. And quite frankly, most of the obstetricians love our program because we screen for a large number of disorders. We also work closely with rabbinical authorities, both in the Orthodox world and otherwise. Obviously, our clients come from all kinds of backgrounds. When we do have sensitive issues that need to be addressed, such as common carrier states, we always advise that the individual have a discussion with their family, usually their parents, as well as their rabbinical figures if there are important decisions to be made. We are included in those conversations very often. I happen to be an Orthodox Jew, so I'm comfortable dealing with the Orthodox rabbis. We actually have a large group of Orthodox rabbis who consult with our organization on our rabbinical advisory board. In the case of other affiliations, we work closely with them as well. Every community has their own need. Every community has their own requirements, and we're comfortable working with all authorities on this issue.
Good. So does the issue of aborting a fetus ever become something that is connected with JPATable or the people that you're associated with?
So the issue of termination, that is not a JPATable issue. It's an issue of myself as somebody who's proficient in Jewish genetic disorders. Unfortunately, I am consulted regularly by both the rabbinical world and the lay world on when those situations arise. And I'll give you an example. We had a situation 3 months ago. This is not through JPATable. This is through my own personal Jewish genetic experience. We offer, obviously, advice to anybody who consults with us, but this comes under my clinical hat. And I actually got a call from a family that was discovered to have a pregnancy of a child with a very serious genetic disorder. The rabbi was consulted with. In this case, it happened to have been an Orthodox rabbi, and there were discussions of whether the issue of termination could be addressed. I explained to the rabbi and to the family what the prospects were of this child should the baby survive pregnancy, and what their options were in terms of termination. The decision was made through the family and the parents and the rabbi to go ahead and allow termination in this case. In the Orthodox community, terminations are allowed in very specific circumstances where there will be great suffering, unfortunately, for that child and that family. There are no broad allowances for termination in the Orthodox Jewish community. In the other affiliations, I've had those similar issues addressed. And what I always tell families is they should be consulting, if they're young couples, with their family, with their rabbinical advisor, and with their physician. And I'm happy to offer advice on that. We don't make the ultimate decision about termination. That's for the family to make. But we certainly advise the rabbis and the family on what the prospects are for that baby. And in the last 20 years, the rabbinical groups from all over the Jewish world have really gone through an education about the needs to consider those issues in terrible cases where the baby is destined to have a life-shortening disorder and one where a child will suffer needlessly.
Interesting. So, of course, you're encouraging people through JPATable and other screening agencies to get to the screening process before you get married, before you get pregnant, obviously, right?
Correct.
And try to figure it out.
We want everybody to know their carrier status well before they get pregnant. I feel that a young couple should never be faced with the terrible decision of terminating a pregnancy needlessly, or even with need, because it's a terrible burden for a young couple to bear, to know that they could have prevented this pregnancy, and now that they didn't, they have to make the decision on termination. So our belief through the program and through me professionally is all screening should be done prior to family planning so they can plan adequately. And if, let's say, a young couple, in my practice, we have over 278 in vitro babies who are born through selective in vitro fertilization, pre-implantation genetic diagnosis, we call it PGD. Those families were all identified carriers and selected out healthy babies through in vitro programs. So we're coming up on 300 babies in my own practice that have gone through that process to have a healthy child. So once a couple is married, let's say, and if they're identified as a common carrier after they're married, they can certainly take that to the next level and go through the option of pre-implantation genetics and IVF. In the Orthodox world, there's a strong inclination of the rabbis to discourage marriages for individuals who are not yet married, who are known to be common carriers. In other communities, there's a whole slew of opinions on that, but certainly that's a decision for individuals to make with their family and with their rabbinical authority.
Interesting. Great discussion of this, Dr. Ditchek. We look forward to hearing from you again on September 15th for the whole state of Connecticut, the Hadassah Group. I want to go on to now another program that you're intimately involved in. You're one of the founders of Kids of Courage. You're the medical director. I think it's unbelievable that you take chronically ill kids on adventures, on trips, and recreate for them a kind of a life, a time that they could never, ever have without that. Why don't you talk about how and why you founded Kids of Courage?
So Kids of Courage, I'm not the only founder. There were initially three of us. One of the founders is not with the organization anymore, but he gets full credit as well. So this organization was founded by individuals who were concerned. It was initially founded by myself, my partner, Howie Kafka, and our previous partner, Ari Adlerstein. So this organization was founded with having in mind that children with chronic illnesses or serious life-threatening disorders most often have complications due to boredom rather than their actual medical condition. Once a child is sick and can't attend school regularly or can't maintain friendships the way other children often do because of their medical restrictions, it becomes a life that's dependent on the people around them to keep them active, to keep them healthy, and to keep them interested. So what we did, our organization is now in our 14th year. We started out with this medically supervised travel program. We are all volunteers with the exception of one administrative person who runs our front office. Otherwise, every one of us are a volunteer. We have physicians, nurses, paramedics, and counselors between the ages of 18 and 25. We travel with the sickest kids throughout the world. We have children who come from as far as Israel, England, Australia, Brazil, and we only take the sickest, most disabled individuals who are in need. We have one-to-one staffing with counselor to camper ratio. If they're very needy, if they have, let's say, diseases where they're on ventilators or oxygen dependent, we have up to 3-to-1 staffing for those individuals. We travel on commercial airliners with oxygen concentrators and other equipment that we've trained people to travel with. We go to destinations throughout the United States. We've even gone outside the United States. We went to the Bahamas and Bermuda on one of those trips, two of those trips. And we travel to destinations that most of these kids can never go to because it's very hard for their parents to pay for this or to even to have the logistics. We bring all our medical equipment with us. We rent out large blocks of hotels. We have our own buses. And we give the kids the greatest time of their lives. But more importantly, we give meaning to our own lives by providing kids with these trips. In the summer, we typically take them to resort destinations like Orlando, Los Angeles. We've gone to Dallas. We've gone to Boston. We've gone to San Francisco, San Diego. And in the winter, we have the largest adaptive ski program for disabled individuals at Mount Snow, Vermont, every winter. And it's been quite an adventure for the kids and for us. We serve over 700 children worldwide, 700 and their families. By the way, there's no cost to the families. The families pay zero. The staff pays zero. We raise all of our own funds to do these trips. And we don't allow family members to come with the child. The child comes alone. It gives them a great sense of independence. And as a result of our trips, we see the children living much longer, much richer lives. Many of them have gone on to go to college if they've been fortunate enough to survive their illness. And we even have those who've gone on to get married.
Excellent. So a couple of points that brought up with this. I was reading about the program. I was astonished to see that it's like a moving hospital when you go with them, right? If anything happens, you're right there. You've got the equipment, you've got the technology, you've got the medicines. I read that 250 volunteers might accompany one of these trips. Is that right? That's amazing.
Actually, yeah, it's even beyond that. For the summer trips,
Wow.
Typically we take about 140 campers. Yeah, it's about 250 to 270 volunteers, including nurses, paramedics, and physicians.
Wow.
We are a rolling hospital. We travel. We call our airliner our hospital in the sky. We're fully self-contained. We even get ambulances that travel with us wherever our destination is, where we either rent an ambulance or we work with another volunteer group locally to travel with us so we can respond to emergencies immediately. We've had many years of experience, many years of emergencies. In our 14 years, we've had, unfortunately, one death in 14 years. That was a young man who was already beyond life expectancy. But I have to tell you, we successfully resuscitated him and got him to the hospital, and he died 3 days later in the arms of his mom and dad, thank God. So they were able to be there with him at the end, which was very important to my medical team, that we were at least able to get him to the point where his parents could be with him. So yeah, it's quite a challenge medically. We are a unique group. We don't allow only one trip. We take these kids on repetitive trips year after year. And I think it's one of the great examples to the world of what we can all do for each other. But most importantly, I want people to understand what the kids do for us. I'm the oldest person in the group. My partner, Howie Kafka, is the second oldest. I'm almost 60 years old. And at the age of 60, it's given me the ability to maintain my peace of mind and to maintain my purposefulness in life by being affiliated with such an important group of kids.
That's terrific. There's one aspect of it, though, that you didn't mention that I think is also terrific, and that's that you give the parents and the caregivers a respite. You give them a chance to regroup, to get some strength on their own, and they don't have that responsibility, that daily hour-to-hour responsibility for the kids that are under their care. That's very, very important, too. Because we all know that the caregivers can get sick as well as the people that they're caring for, right?
You're very intuitive, Sheila, and you're very correct. The respite given to these parents is probably more important than the experience of the kids themselves. By the way, when we have parents drop the kids off at the airport, typically we'll see their suitcases in hand because they themselves are going away for a few days just to get some peace of mind. But chronic disease and life-threatening illness in children and young adults can destroy families. The divorce rate is much higher in these families, unfortunately. And I can tell you that we get great satisfaction knowing that while we're caring for the kids, the family is off just being a family again, and not having to worry about who's going to give their kid their medicine, or who's going to suction their tracheotomy, or who's going to provide them the oxygen they need. So yes, the respite is more important than the experience themselves for the kids. You're correct.
Yeah. Great. What a great program. I'll show a few slides of it later, but before we do that, we want to talk about the current things that are happening, and we want to talk about COVID-19. As a physician in the Brooklyn community, in the Orthodox community, you were one of the first to sound the alarm when the COVID crisis occurred. Tell us about it and your involvement. And later on, I know you wrote a letter to the president, which we'll talk about also. How did you know that you needed to sound that alarm and get people to stop congregating the way they were?
So in early March, I was recruited. There was a task force or a working group of volunteers, epidemiologists, infectious disease, and biothreat experts who had followed the data very closely. And these are people who are trained to recognize threats, biothreats, throughout their entire careers. They had followed the issue in Wuhan, as many experts were. And this working group of experts were able to pinpoint that the next epicenter here in the United States after Washington State was going to be right here in the New York, Northern Jersey area. So I was contacted by one of the founding members of that working group who said they need a clinical lead here in the New York area to warn the communities that we were about to get hit with a very serious pandemic threat. This was at a time that the New York City Department of Education was refusing to shut down schools at the early days. This was at a time when most people were in denial that there was a serious threat to our society. So as you can imagine, I took a lot of pressure and heat. I actually presented a slide deck to a group of administrators, principals, and community leaders here in Brooklyn and the New York area the day after Purim this year. And I showed them the numbers, and I showed them what the threat was and why we had to immediately close down the schools and take immediate shelter in place advisories into consideration. I can tell you it wasn't a popular position at the time because people were upset that the alarm bells were ringing before the government rang the alarm bells. But this working group was very proficient at recognizing the threat. I became the clinical lead for the New York area for that working group, and we've now evolutioned after many revisions of the working group to a research-oriented working group. I'm actually the co-investigator on a number of clinical studies right now, COVID-related, and that was how I got involved with it initially.
Interesting. So it's interesting that you sounded the alarm even before, as you said, the state of New York started the stay-at-home orders. And a lot of people have given Governor Cuomo a lot of credit for the way he managed the virus. But many people also say that he probably started a little too late, and he probably sacrificed many lives because of that, starting too late. And during that time, you also wrote a letter to President Trump asking for more equipment. Tell us about that. What impelled you to write to him directly rather than go through Cuomo or other leaders?
So I wrote to the governor as well. To be fair, the letters went to the governor and to the president. I didn't limit it to the federal agencies.
Okay.
What I recognized is that, as many of us did who were in the hospitals at the time, we were watching the medical system get overrun very quickly during those early weeks in March and April. We were several days away from critical crises. We were already having shortages of critical medications needed for sedation to intubate patients and keep them sedated. The ventilators were at a critical breaking point in terms of the number of ventilators that were needed at the time. And quite frankly, the hospitals were scrambling to get equipment and medications. Our working group actually donated ventilators and high-flow nasal cannulas and PPEs to many hospitals in the New York City area because we were able to get that equipment in a very quick fashion. But we recognized that it wasn't enough, that we needed to reach out to the federal and state governments. The way it works is the federal government was supposed to divvy out equipment to the state governments. The state was supposed to divvy it out to the city governments and localities. But quite frankly, there were delays in all of those areas for obvious reasons. We were in the middle of a pandemic. So I wrote a letter of urgency to both the president and the governor, encouraging them to act quickly before the hospitals in Brooklyn and Queens were overrun. And Brooklyn and Queens, the hospitals were in terrible danger of collapsing under the pressure of the early pandemic.
Did you get a response? And do you think that what happened after that was handled well? Did the state of New York do a good job? Not to mention, which I will ask you later, do we have a proper national strategy for this now that we see more outbreaks all around the country?
So the answer is the federal government did release much of the stockpile initially, the state as well. We did have a lot of issues with the equipment that was received from the stockpile. It's a great learning curve because many of the ventilators that were in the stockpile were released not in great working conditions, so the hospitals had to retool them and had to do a lot of repairs on the fly. But there was some response at the federal and state level. I can tell you that the federal and state government don't typically get on the news and say we're responding to any one individual's letters. I don't think it works that way. But I think they were receiving pressure for a number of locations and a number of individuals and groups. I was just one of them. I can't take credit for that. But the answer is they did do a better job once they realized that the system was being overwhelmed. What I was asking for was very simple. What I said is New York is the epicenter now. Send us everything you have so we can save lives in New York. As soon as the wave passes New York, you can send it to the next epicenter, Chicago, Dallas, Washington, wherever it's needed. It's logical. And I think that's what was missing at the early stages of the pandemic, both on the federal and the local levels. There wasn't a lot of communication with people on the ground who had logical solutions. A lot of them were, more very sophisticated solutions for simple problems. I was looking for a simple solution for a simple problem, which was give us what we need now. We promise you we'll ship everything to the next state that needs it next. And as you can see, that's exactly what's going on right now. Resources are being shifted as the need arises throughout the United States.
So, Doctor, what is your thinking now about how this is all being handled and what's happening now? We have outbreaks in the South and the West, 1,000 deaths a day still happening, and we have many, many controversies about how to open up our economies, our stores, our schools, and we still don't have enough testing. What are your thoughts about the future of handling this disease as we go forward?
Well, I think Dr. Fauci said in an interview yesterday, which I think people should listen to closely. He was interviewed by the JAMA, Journal American Medical Association radio network. I didn't watch the whole interview, but I got bits and pieces. And what he said is, right now we're at about 65,000 new cases a day in the United States, which is astronomical. In order for us to be safe once the fall and winter comes, we have to be below or at about 10,000 cases a day in order to prepare for the influenza, the other respiratory virus, which is going to hit in the fall and winter, and to prevent the catastrophe if both viruses hit prior to the vaccine arrival. So I think the goal should be right now to get the cases down to a manageable level. 65, 70,000 cases a day is not manageable in the United States. It will lead to many more deaths. The current prediction is that we will see 170,000 deaths by August 22nd, which is a terribly high number. So the answer is, I'm in the category of individuals who believes that there should be universal use of masks and social distancing right now. I don't think any American should walk out onto the street without wearing a mask, whether you live in New York City, where it's quiet right now, or whether you live in the Midwest, where it's not quiet right now, or South Florida. I think every American should be wearing a mask above the age of 6 or 7. I think that'll reduce the case rate dramatically throughout the United States. The CDC has taken that position, and it's a correct position. I think we should be limiting large gatherings. I don't care what large gatherings they are, whether they're groups of 70 or 200 people. I think they should be limited significantly so we can prevent community spread. And I think we should do much of these things until the vaccine arrives, which will hopefully be late December, early January. But I am in the group of scientists or clinicians that believe that masks are the only thing we have to offer right now to decrease the number of cases. We have great new therapeutics. We have great research going on. We have great vaccine options coming forward. But as of today, on today's August 4th, the only thing we have today to prevent community spread and transmission is the proper use of masks and social distancing.
And would you agree with me? You need national leadership for that. Dr. Fauci is saying all the right things, according to you, but people aren't listening in positions of power to make that come true. And we have issues of politicization of wearing masks. Did you ever think our country would come to that?
No, I'm disappointed on both sides of the aisle. I have to be honest with you, Democrat and Republican, that this has become politicized. I'm an apolitical individual as far as my medical knowledge goes and scientific perspective. I believe Dr. Fauci is apolitical as well. I don't think his recommendations are based on politics. I think on both sides of the aisle, we have to come together and recognize that when I was watching people die from COVID during the months of March, April, and May here in the New York area, the virus did not ask you whether you were on the right or on the left, Democrat or Republican or otherwise. This has nothing to do with politics. This has to do with how we behave as a people. And as an American society, we need to come together on this issue now if we want to save lives going into the winter. Right now is the time to establish those strategies. Yes, we all made mistakes. All of us made mistakes in the clinical management. We made mistakes in the mask recommendations early on. We all made mistakes. But now we know from the data that masks save lives, that social distancing saves lives. And that should be our position, whether we're Democrat or Republican right now.
Okay, great. Thank you for that, Doctor. I want to now finish our discussion by showing you some slides that I made in a little PowerPoint for you. I'm going to put them on the screen now. There you are, Dr. Ditchek and Kids of Courage, right? Can you see that?
Yes, thank you.
Okay, great. I was happy to do that. And I just wanted you just talk about this map because I thought it was a nice
So this
explanation.
Yeah, this shows you the immigration patterns after the collapse of the second Beit HaMikdash. You could see the Sephardic and Mizrahi Jews went south to the North African and Arabic countries, and the Ashkenazim went north to the European countries primarily. And that's how the map fell out. And this is the area where you see Ashkenazi is where most of these mutations apparently developed around the 14th and 15th century.
Great. And this, can you talk about this for a minute?
Yeah, so this basically a little hard to describe from this slide, but basically this shows that it takes two to tango. You need both parents must be carriers for a gene in order to have an affected child. If both parents are carriers for a gene, they have a 1 in 4 chance of having an affected child. That's the dark blue G at the bottom of the screen. If only one parent is a carrier for a gene, they only have chance of having carrier children, not affected children. Again, takes two to tango. You need a gene from each parent to have an affected baby. 1 in 4 is your likelihood of having an affected baby with each pregnancy.
Right. And that was just, these are just a list of some of the
yes, if I had my reading glasses, I suspect this would be telling you the gene frequency for certain diseases. Gaucher, you could see, is 1 in 16. It's actually 1 in 12 to 15. And if you look for a disease like spinal muscular atrophy, which is a muscular dystrophy type disease, it's 1 in 40 or 1 in 41.
Right.
So you
Okay.
see the whole. But the point is, whether you're a 1 in 12 carrier or a 1 in 300 carrier, if your spouse is a carrier for the same gene, your risk is the same, 1 in 4 in each pregnancy.
Got it. Oh, this is just talking about the gene thing. Oh, and here's your JPatable. That's the logo for your organization, right?
For people who need information, they can go to jpatable.com. I'm sorry, jpatable.org.com will take them there as well. We're a 501c3. As I said, the new program is being relaunched on August 21st. And for most people with insurance, the cost of the program is anywhere, it'll be $99 to $140 for those with insurance for full screening, full genetic counseling, and full matching programs. So it's a very cost-effective program.
And this is just your statement about how you brought JPatable to fruition.
Yes.
Okay. And here's Kids of Courage. You've got kids in wheelchairs or kids who walk. But I think that's a great logo. One of your logos.
Yes.
And just some slides. Is that you in that trip?
That is me in the front with the orange hat. That's our medical team for this trip. And just to show you the diversity of the team, we have physicians, paramedics, nurses, and EMTs. And the guy with the long beard with the hat at the top, the big guy, is a U.S. Army Ranger medic named Iran, who lives in Houston, Texas, who served 3 tours of duty and now serves for Kids of Courage every trip.
Wow.
As one of our nurses.
And where was this trip to?
This, I believe, was Orlando, if I'm not mistaken. Also in this picture in the center is our head nurse, Miriam Kaplan, who's been with us for all these years, and my partner, Howie Kafka, is standing next to me. He's actually our chief paramedic, and he's one of the most experienced paramedics in the United States. He also works for an organization called Mapsala, but he is one of the lead paramedics in the United States.
And every one of these people is doing it voluntarily.
Every single person you see is a volunteer.
Fabulous.
I guess
so. You have a nice association with the airlines that help you with this.
We used to have a unique relationship with United. Now we fly commercial on many airlines: JetBlue, United, American. But yeah, our airlines have been great to us. They make great accommodations for our kids, and they bend over backwards. These are just a group of the kids in one of the early trips. As you could see, every camper has counselors with them. And these young men all have the same disease. They have the disease of familial dysautonomia. And these guys normally could never be on a trip other than with our group. And here's some of the young ladies in our group. Incredible, actually, to give you an example of what the group does. One of the young ladies in this picture in the wheelchair lost her mother last year. Her dad has passed away many years ago, so she's now alone, and Kids of Courage is now her family. So we care for her. We keep up with her on a daily basis. And in fact, I've been saying Kaddish for her mother because she has no siblings who could do that.
Well, I realize the other thing that this does is it gives them friends and friendships and connections, which they might not have if they're stuck home alone being cared for by caretakers of their families, right?
Right. And those connections continue all year round. That's what keeps them alive.
Great.
This is in Arizona or Nevada. I'm not sure. I believe it's Nevada, actually. We were in Las Vegas for one of our trips, and this was at one of the outdoor events. I think we actually, the kids had instructions on shooting that day. Something, again, a disabled kid could never experience in their life. So we had licensed instructors teaching them how to do that, and the kids loved it. It was phenomenal.
So, Doctor, but how many trips do you go on generally?
Oh, I haven't missed one yet. 14 years I'm on every trip.
Oh, that's wonderful.
This is Howie Kaufman. Neither of us have ever missed a trip. This young man unfortunately passed away last year. His name is Libby. He had muscular dystrophy, and he was fully ventilator dependent. He was on a speedboat here with two of our counselors, but unfortunately he passed away last year at the age of 31, I believe, 32, and we miss him terribly, but he was one of our long-term campers.
Sure. Doctor, how long is each trip? I mean, how many days duration generally?
Summer trip is 8 days. The winter trip is about 4 or 5 days, the ski trip. The weekends are 3 days each, sometimes up to 4. And then we have single day events, which are 1 day, like Sunday fun days, or trips to a sporting event, amusement park, Broadway show, things like that.
Now, when you go, do you ever bring members of your own family on the trips with you, or you just go with the staff?
Well, thank God I'm at the point of grandchildren. I still have a 19-year-old daughter living at home, but all of my kids were raised in Kids of Courage. They were all counselors and staff members throughout the years, and they all maintain relationships with their previous campers. At this point, I pay to take along my grandchildren on some of the trips because I want my grandkids to see this firsthand and to be part of it and to learn how important it is to have this in your life.
Great, great. There's another lovely logo.
Yeah, we're struggling with logos.
You don't have a set one? Is that it? Because I found several that were good.
We have a few, but we're a limited democracy. We let the staff decide on a lot of this, and they're young and they're idealistic. So,
yeah. Well, there's another one coming. I think I have further along
yes.
that I liked also.
This is another one
This
of
is like a fun trip.
trips.
Yeah.
The young man in the middle is ventilator dependent. He's from Houston, Texas. His name is Itzy, and he was hit by a car at the age of 2. He's now 32, 33.
Wow.
He's quadriplegic, who's actually to my knowledge, the longest living ventilator-dependent quadriplegic in the world, due to the great care of his parents. And Itzy's with us on every trip.
You can buy a T-shirt with that on it. Mm-hmm.
Yeah, this was just the marathon. Every year we do Race for Courage. We do a marathon, usually in Miami, which is both a fundraising event, and we always bring along about 20 campers. So this is just from the Race for Courage marathon.
Now, here's a blind skier.
Adaptive skiing event. This young lady is blind since birth. Actually, she's blind since the age of 2. I apologize. And yeah, it's one of our adaptive skiers, and she skis every year. We have kids on ventilators who ski, by the way.
Yeah. So I've read you have about 500 kids that are in the program. How many will go on a trip at one time?
140 on the summer trip, 50 to 60 on the ski trip. Weekends are anywhere from 20 to 50. Another one of our young ladies. The young lady on the right, actually the counselor in that picture, just left to medical school in Sackler in Israel this week.
Oh, neat. Now, where was this? Do you know?
Somewhere. I'm having trouble seeing it. I think it's Orlando. I think it's in one of the outdoor events at Orlando, I believe. And this is on the tarmac. This was a United Airlines 757 that we chartered to take the whole group. And this was on a trip to Orlando. This young man is one of our young men with cerebral palsy. He's actually a speaker. His name is Zach. He lives in Jersey, and he's a speaker for the organization and other organizations as well. He's a very eloquent young man who speaks beautifully about his life as a individual with cerebral palsy. And this is the challenge of these kids. Although he looks physically disabled, which he is, many people assume these kids are cognitively impaired, which they're not. Our program is limited to individuals with physical impairment who are cognitively appropriate for age or close to it. Zach is brilliant, but many people who meet him may assume he is cognitively impaired. He's anything but cognitively impaired. He's a genius.
That's a good point.
I believe that's our man Itzy again from Houston. And this was at one of our events with, I believe it was one of our football training events that we were at. Those are some of the young ladies in our group as well, obviously. And again, if I had my glasses, I could tell you a little bit more. I apologize.
Everybody looks like that they're having fun anyway. There's another
Yes.
T-shirt with the Race for Courage on it. And there, I guess that's you.
That's me in better times, yes.
Well,
I'm always
how many?
there. Howie and I never miss a trip, and we're always there. And the truth is, I have found with age, although it's more challenging, what you'll notice is that Howie and I are usually first online to schlep and to lift kids and do the heavy lifting because we want to be role models for the staff. And I think it's important for them to see us at the events working hard.
And then here's the letter that you wrote to President Trump on April 5th, 2020.
So this letter triggered a visit by Fox and Friends. I appeared on Fox News after this letter was written in an appeal to the federal government and to the state government to get us more equipment that we needed desperately at the time. And by the way, I want to add, Sheila, you know, one of the criticisms I hear from some of the political naysayers is, do you see, they said they needed more ventilators, and in the end they had enough. I find that fascinating, that criticism, because yes, we did have enough ventilators, but it was only due to tremendous efforts, not only at the federal and state level, but at the local levels to guarantee that. There was a period of time where we had critical drug shortages for about 2 weeks where we could not get medications that were critically needed. And I think people should understand that. We came very close to the edge around mid-April here in New York.
Well, as you say, it should be completely and totally science-based and nonpartisan.
Correct. That's our logo.
Here's the logo. I guess this is the main logo now, right?
Yes,
yeah. Okay. And I think that's our slideshow that I was happy to bring to you.
Thank you.
Yeah. And now we can get back to the two of us and say goodbye. So, Doctor, we've touched on so many of your interesting passions, your passion for young children and kids of courage, your passion for what's happening with COVID-19 today, and your work with Jay Paddable and screening for genetic diseases. Very, very important. Any final thoughts as we sign off today? And we'll see you again in September.
I want to thank you. I just would quote Dr. Birx early in the crisis, not only relating to COVID, but relating to genetic disorders. She said early on, and I think she should repeat it, that the solution to COVID has to occur at the community level. And I believe the solution for genetic disorders has to occur at the community level, doing programs like you're doing with your organization and your show. There's no broad brush to fix these problems. We have to work on a community level, each of us, to solve these problems so that we don't see any more suffering in this world, whether it be from genetic disorders or whether it be from COVID. And I feel passionately about that.
Okay. On that wonderful final note, I want to thank Dr. Ditchek and thank you all for watching. We'll see you next time on Talkback. Bye.
Thank
Bye,
you.
Dr. Ditchek.
Take care.
You.